medications and the interventions that the cardiologist will have. And I'm sure that Professor Dr. Wander is around with us. He'll also agree that the initial concept of a step care management, which was there, and which used to be an approach for the management of a heart failure, which usually used to start with the diuretic therapy and then slowly used to up titrate the patients on which either beta blockers, then ARNIs and ACEs and ARBs. Those were. Now it has technically narrowed down to a combination therapy right at the start with choosing the right kind of the drugs. And not only that, it has been very clearly, I would say recommended by the various organizations, including the European Society of Cardiology and American Heart Association, that the maximum or I would say the amplitude of the therapy should be adequate, and that should be reached within 4 weeks of the therapy. So giving overview of a overall diabetes and the related challenges that SGLT2 definitely address as far as the heart failure is concerned, is that these are technically the drugs which have changed the way we are managing heart failure patients, especially whenever it comes to heart failure and diabetes. What do you say?
Okay. So you mean these are the really first-line drugs to be used in the heart failure?
I may not be so much, I would say, aggressive on suggesting that they are the first-line drugs, because you need to assess the patients on the various clinical parameters. See, suppose somebody is an acutely decompensated heart failure and presents to you with a fulminant florid pulmonary edema, probably there is the place where diuretics will come first, or you need to deload these patients. So you need to assess the patients depending on the clinical presentation and then choose your drugs wisely.
You mean you have to stabilize the first
yes
problem?
Yes,
and then you start this drug.
Yes.
Okay. Yes. So now I will come to the Dr. Wander. He's a senior cardiologist. After the SGLT2 inhibitors, they are writing the anti-diabetic treatment, all the cardiologists, without any fear. So you are using in heart failure also. What is your opinion about these drugs? Dr. Wander, please.
See, as Dr. Chhabra, you are also implying, SGLT2 inhibitors, of course, first came as anti-diabetic agents. And all the three outcome trials showed that they significantly reduced, whether it was with dapagliflozin, empagliflozin, or whether it was with canagliflozin. All three showed that there was significant reduction in heart failure. And CV events were significantly reduced. And it was the initial three outcome studies which paved the way for the DAPA-HF trial and the Emperor reduced and the Emperor preserved trial with empagliflozin. And to our actually good luck, the results of DAPA heart failure trial, which were published about 3 years back in the New England Journal of Medicine, and even the Emperor reduced trial. Now, heart failure is conventionally divided into three: heart failure with reduced ejection fraction, when the ejection fraction is less than 40%, heart failure with mid-range ejection fraction, when it is between 40 to 50%, and heart failure preserved ejection fraction, when it is above 50% the ejection fraction, and you have features of dyspnea and raised BNP levels or NT-proBNP levels. So in reduced ejection fraction, we have conventionally had three class of agents which reduce the mortality. And there has been a lot of work. In fact, we have also participated in the Asian heart failure trial registry, I would say, in which 6,000 patients were included. And our endeavor, and most of the guidelines also, in fact, the Indian guidelines also try to emphasize and reduce the physician's inertia, that all three agents, one of the RAS blockers, now the conventional RAS blocker we had was ACE inhibitors and the ARBs or the receptor blockers. But with the advent of the ARNI, the angiotensin receptor neprilysin inhibitor, the sacubitril/valsartan combination, that has actually shown benefits in the Paradigm HF trial as compared to the conventional RAS blockers. Beta blockers, of course, bisoprolol, metoprolol, succinate, or carvedilol, one of the three beta blockers which are used. And third is the mineralocorticoid receptor antagonist spironolactone. So conventionally, we used to say these are the three pillars of treatment of heart failure, which reduce mortality, or one can say which improve the longevity of life. But after the results of the DEPA-HF and the EMPEROR-Reduce trial, now today we talk in terms of four pillars of treatment of heart failure. And all patients, the DEPA-HF showed that 50% of their patients did not have diabetes, whereas the other 50% patients had diabetes. The amount of benefit in terms of mortality reduction was similar in diabetic patients and in non-diabetic patients. So all patients of heart failure with reduced ejection fraction that I treat, at least, my effort is to put them all on dapagliflozin, because it is now available in our country at a relatively reasonable cost. And it is the fourth pillar of treatment in by the European, the Indian, or even the American guidelines. So in fact, initially, when we attended some of these meetings with the endocrinologists, there was a lot of fear of urinary tract infections. Now that is known that UTIs are not increased. It's just that the genital infections are somewhat increased. But for that, people can take precautions. Some fear of four-year gangrene, some fear of limb amputations with canagliflozin. Sick day withdrawal, of course, is still important in these people. In fact, what we today discuss actually in most of our meetings is, should we earlier we used to have a concept of sequentially adding these agents. And conventionally, we used to say, first start a RAS blocker. Once your patient has stabilized, then you add a beta blocker, and then add an MRA or a mineralocorticoid receptor antagonist if your patient is not responding. Now, actually, the concept is that, in fact, pre-discharge, your patients should be on all four agents. Because if you look at the DAPA-HF trial, just as we had with statins in acute coronary syndrome, the benefit appears within 28 days of its institution. So now the concept is, why should we delay the benefit of these forms of therapy to our patients? So it's an upfront use of these agents that your endeavor should be that most of your patients are put on these agents.
Okay. Thank you, sir. You mean we have to start even before the discharge?
Yeah, see, most of these heart failure trials have been done on an OPD basis, but there is a meta-analysis published in JACC this year, which shows that there are multiple small trials in which these agents have been used in pre-discharge. And that is the practice actually with most of the people, that we do not delay the usage of SGLT2 inhibitors in our patients, because the benefits are very strong. In fact, there is an analysis which was published by Milton Packer and others. One of my mentor, Dr. Inder Anand, is also actually part of this analysis. If a 55-year age individual is given all four of these agents, you will add 6.5 years to the longevity of life of these people. And we all know the mortality of heart failure. There is a lot of now data from Trivandrum and other places in India. There is an ICMR study also. The 5-year mortality is 50%. So if there is a combination of agents that can impart so much of longevity of life, we truly are actually blessed that we have all these four class of agents, which when used pertinently and with precautions, we can give benefits to our patients.
Yeah. Early use, it will reduce the admission due to the heart failure, I think.
That's true.
Now I will come to the Professor Dr. N.P. Singh, Narendra Pal Singh. You are doing the practice of nephrology, maximum practice of nephrology. What is your opinion about these drugs as per point of view the nephrology?
Thank you, Dr. Chabra, and thank you all the organizers for this chance. I think when it comes to chronic kidney disease, we have to look at two aspects. Most of the patients who have a chronic stage, most of them actually die of cardiovascular morbidity and mortality. They have a cardiovascular morbidity.
Your voice is not clear.
Can you hear me now?
Much better.
So I said that any patient with chronic kidney disease
we are concerned about two things. One is his progress to end-stage renal disease, and second is even before progressing to end-stage renal disease, many of these patients die of cardiovascular morbidity and mortality. On the other hand, many of these patients with chronic kidney disease, when they undergo a dialysis, they have associated heart failure. Now, any patient who comes to us with acute coronary syndrome or has a heart failure, a significant number of patients do have renal dysfunction as well. So that is why Ronco, in his a decade back, gave this classification of cardiorenal syndromes: type 1, type 2, type 3, type 4, and type 5. The problem with the CKD drugs or the cardiovascular drugs was when we were treating heart failure, the renal dysfunction was worsening. And it was also when we were trying to treat CKD, many of these patients were developing heart failure. So we were trying to look at a molecule which would actually look at the underlying pathophysiology of RAS inhibition or RAS activation, sympathetic overactivity. So we had drugs like ACE inhibitors and ARBs. We had drugs like beta blockers. We had drugs like other diuretics. But as I said, all of them were associated. They were not as safe, and they were all these drugs had to be discontinued because of the side effects during the late phase of the CKD, that is stage 4, stage 5. Now, I'll talk first about ARNI because we talked a lot about SGLT2 inhibitors. When ARNI came, then we thought that probably the same issue is going to come back when we would use them for heart failure, the CKD will worsen. Now, recent studies very elegantly have proved that there is a difference between worsening acute kidney injury and increasing serum creatinine. These are two different things. What ACE inhibitors, ARBs, and now ARNI is doing is when you start these patients for heart failure, there is resetting of the serum creatinine, which in fact, these are the patients who go on to develop benefits in a long-term way. Similarly, because of their hemodynamics, their hyperkalemia, their other side effects which were associated with ACE inhibitors and ARBs were much less. The patients we were able to start these patients on ARNI even in stage 3 CKD, and now meta-analysis has already shown that these drugs not only can be safely given in CKD, but they have been found to be beneficial and they can prevent the progression of chronic kidney disease as well. So now we are much more confident of using ARNI. Of course, one has to be careful that the ARBs, if they have been started, has to be reduced, stopped first, and then we have to which is what is always done. ARNI has to be started with a low dose. Always look at potassium because it is the hyperkalemia which can further worsen heart failure. Second is the use of SGLT2 inhibitors. I think I agree with all the panelists that this drug has had a revolutionary impact not only in diabetics, not only in heart failure, but also in patients with diabetic kidney disease. Now, these are the drugs which, when started, we were very careful. We had suspicion of these patients causing AKI and then further worsening of the renal failure. But the trials like Credence, the trials like DEPAC-CKD have clearly shown immense benefit of these drugs on not only preventing the progression of chronic kidney disease, not only treating diabetic kidney disease, but also in non-diabetic kidney disease because of their pathophysiological impact, because of their activity, because of their action on the glomerular tubular feedback. These have been found to be wonderfully reversing all the pathophysiology which was causing intraglomerular hypertension. So this is a drug which can not only impact diabetes control, but more importantly, they have immense renal benefits, resulting in a significantly reduced cardiovascular as well as renal outcomes. All these studies had to be stopped early, especially for the renal effect, that the difference was so significant as compared to placebo that the trials were stopped in between. So I would say that to begin with, yes, we need to be careful, and I would agree with Dr. Monder about the 6 days rule for these two drugs. But by and large, all these patients do wonderfully well when we start them on patients for even early, and now up to 30 ml of GFR, we can safely start these drugs. And if they have been already started, they can be continued well beyond. So is true of ARNI. And when it comes to hyperkalemia, I would like to hear to say that now the trend has changed. Instead of stopping these drugs, we generally ask the patient to take less of a diet we try to change the diet for potassium. And also we tend to give potassium binders on which our newer drugs are now available and add a diuretic so that hyperkalemia can be tackled without stopping ARNIs or ARBs. So, just to conclude, I would say that these two drugs are wonderfully, introduced drugs not only for their benefit on cardiovascular outcomes, but also immensely benefiting patient. Patient remains the same. He has atherosclerotic disease, he has CKD, he has heart failure, he has cardiovascular disease, and these two drugs to date has been found to be really impacting the hard endpoints of mortality, both renal as well as the non-renal outcomes.
You mean EGFR and the potassium is very, very important in the measurement of using these drugs?
Yes, we need to
The
monitor these
EGFR.
patients.
EGFR and the potassium level.
Yes. And now there are very clear algorithms available which can help you to start these drugs with a slowly improving the dosage. And then, okay. Thank you, Dr. Saab.
Now I will come to the most important, Dr. Ashok Taneja. He is a physician. He has the holistic approach to treat the patient. What is your opinion? You have to see the weight, hypoglycemia, so many things you have to see. Now over to the Dr. Ashok Taneja. What is your opinion about these drugs? Being a physician.
Dr. Good evening, everyone. Good evening, everyone. My thanks to all of you for giving me an opportunity to talk to you on this very important subject, heart failure treatment. As a physician, my viewpoint is that my patient should be happy. If patient is happy, I am happy, I am earning, I am happy. And to see that whether the patient is happy, his happiness quotient has gone up or not, I will rely on two aspects of life. That is one, quality of life, another is quantity of life. Quality of life means how much percentage reduction in hospitalization or the symptomatology of the patient has improved after adding both SGLT2I and ARNI. In fact, when I was going through the literature, I have found that percentage hospitalization with SGLT2I alone reduces by around 12 to 16%, whereas with ARNI is almost the same. But if we combine both of them, the hospitalization risk is further reduced to the tune of around 20-22%. That is a very good index or very good proposition that the patient is requiring less hospitalization, less expenses, and his quality of life is improving. Now, going further, that the European Society of Cardiology published an article in 2020 by Kumi and Huang, then Canvas trial, EMPA reg trial, DEPA heart failure trial, Emperor heart failure trial. What they showed, the conclusion was very simple, very clear-cut mandate that if you combine SGLT2 and ARNI, what it does is it changes in the LV pattern. Ejection fraction is changed. Means there is improvement in left ventricular ejection fraction, reduction ratio of E/A ratio, that means suggestive of diastolic function, that is also improved. E/E prime ratio further is improvement. And as recently Dr. N.P. Singh said, there is improvement in renal failure parameters also. So if you combine both SGLT2 and ARNI, what you get? You are getting improvement in renal failure, you are getting improvement in heart failure as evidenced by echocardiography. I think these two parameters are good enough to suggest that instead of using SGLT2 or ARNI plain, we should use the combination of both of them. Now, as Dr. Wander said very correctly, traditionally, it was lenoxin, diuretics, then came ARBs, ACE inhibitors for management of heart failure, then came ARNIs. ARNI provide a good arm to the armamentarium which was available to us, and then SGLT2. Initially, introduced as anti-diabetic drug, but found that in heart failure, it has tremendous power of improving the outcomes or the functions of the kidney as well as the heart. So if we could logically, if the two things are there and both are complementing to each other, and if we combine both of them and we get good result, I think it is a good combination and going to be having far-reaching consequences as far as heart failure treatment, especially with reduced ejection fraction is concerned. That is a good, going to be a good combination. Now I come to the second aspect, that is quantity of the life. Now we are not concerned alone with the quality of the life. That patient is feeling better and patient is feeling okay, his family is happy, but we have to see that it is increasing the quantity of life or not. As Dr. Wander said very correctly, that 6.5 years are added to the life if the treatment is started early and all the 4 drugs are given. And I think it is going to be the modus operandi of our practice in future, that whenever a patient of heart failure is discharged, we put them on ARNI as well as SGLT2 inhibitors, of course, along with diuretics and whatever the patient requirement is something else. And you will find that quantitatively his life has prolonged. Once his life is prolonged, definitely it adds to the societies that and to the medical fraternity also, that we are progressing at a very good pace. We are giving benefit to the society as well as to the nations. But there is a word of caution. Where we are seeing the happiness, the quality of life, what is the side effects? Is there any side effect which is going to create trouble for the patient, or patient is feeling inconvenience? Yes, SGLT2 inhibitors, the main side effects is considered to be the recurrent urinary tract infections, or sometimes increased risk of hip fractures. But I found that recurrent urinary, in my own practice, I have seen many times that males and females, if I start in males, particularly if he's a Muslim, because of the circumcision, the incidence of UTI is very, very less. But certainly females get more urinary tract infections. And I always advise them with
Dr. Taneja, we are talking about the heart
plenty
failure.
of water, plenty of liquids, and genital wash. They should. Yes. These are the side effects which is coming up as a part of the SGLT2 treatment.
We'll talk later on about.
So we have to take care of that. And the third is the drug, which drug, whether it is DAPA, ANPA, or KENA in SGLT2 inhibitors, or it is a class effect.
Dr. Taneja, we are talking about the not class, we are talking about the SGLT2 inhibitor as a whole, not as a single drug.
Yes, I have gone through the literature, but I have not found any difference between the three, that in heart failure with reduced ejection fraction management, which SGLT2 inhibitor scores over the others, which I have not found. Maybe Dr. Wander may or Dr. Shashank Joshi entertain us which drug should be the better to use as a part of SGLT2 inhibitors. But certainly, if you combine the two, SGLT2 inhibitors and ARNI, definitely it gives a boost to the cardiac function as well as to the renal functions.
Okay, thank you. It means they have changed the scenario of the heart failure treatment. So now I will come to the Dr. Girish Mathur. He is a president-elect. Dr. Girish Mathur. Dr. Girish Mathur.
Yeah, Dr. Chavda.
SGLT2 inhibitors are used in the diabetic patient. Would you like to use in the heart failure treatment if patient is not diabetic heart failure? Would you like?
Yeah, Dr. Chavda. Actually, DAPA-HF trial proved beyond doubt that SGLT2 inhibitors provide protective benefits to heart failure patients, regardless of their diabetes status. And FDA approved dapagliflozin for the treatment of heart failure with reduced ejection fraction about 2 years back, with or without diabetes. It was the first time that a drug which was developed for the treatment of diabetes was approved for the treatment of heart failure. So we should rather use dapagliflozin for the treatment of heart failure It has rather revolutionized the treatment of heart failure. ARNI and SGLT inhibitors for last 5 years have transformed the treatment of heart failure, and we must provide the benefits of these agents to the patient of heart failure.
Okay. We can use in the
Sir, even
heart failure without the diabetes.
Certainly, we must.
even the Emperor HF trial, they have claimed that we are better than DAPA. But still, I don't know. The debate has to continue, has to go on. Which agent out of them is better?
Thank you. Thank you,
But
Doctor.
US FDA approved DAPA.
Okay. Thank you. Now I will come to the Professor Jyoti Paul Roy. Is there? Is a Dean-elect. Dr. Jyoti? Dr. Jyoti is there? Where is he? Dr. Jyoti Paul? So
He's not in the list. He's not in the list of participants.
he has joined, I think. Anyhow, I will come to the Dr. MBS Chawla. He is the honorary chairman of the ABA Delhi State Chapter. Professor MBS Chawla, beta blocker is also used, as the Dr. Wonder was saying. Think these drugs will change the beta blocker, replace the beta blocker in the heart failure.
Dr. Chawla, first word of advice to everyone is don't try to place one drug over the other. All of them have their place in the treatment, So this is kind of your armamentarium that has been widened with the availability of these drugs. But actually it is you who has to choose wisely in which set of patients, which drug is to be used. And as Dr. Wander has rightly pointed out, you can't stress one drug over the other. It is very important, recently in April 2022, new guidelines, they have been issued that they say you start all the 4 drugs right from the word go. Earlier, what we used to do, we started with the monotherapy, build it up, and then added sequentially the second drug, third drug, and fourth drug. So that part has been gone. As far as beta blockers are concerned, again, let us remember that this is not the class effect. It is only 3 beta blockers. That is metoprolol succinate, that too in sustained release form, bisoprolol, and carvedilol, which are used in the management of heart failure. Other beta blockers, they are not effective. In fact, for example, if you take example of sotalol, that is, found to increase the mortality. And one very important point, which so far has not been stressed, that you start with low doses, but try to build up. That is very important, to the dose which has been used in the trial and has been shown to reduce mortality. For example, say you are starting with bisoprolol, you start with 1.5 or 2.5, but you then build it up to 10 milligram, which is the dose that has been used. Metoprolol succinate, you start with 12.5 or 25 milligrams sustained release, but you can go up to 200 milligrams, right? So that part is very important that you must keep in mind. So they have their place in treatment. It is not that ARNI has come and SGLT2 has come, so beta blockers will go, no. But that is very important that it is not a class effect. Unmute yourself, unmute yourself.
Dr.
Chawla, you are muted.
Yeah. Dr. Jyoti has come, I think. Thank you, Dr. Chawla, for the nice comments. And Dr. Jyoti is there? He joined, I think.
Yes, he has joined. You have to
Dr.
ask him to
Jyoti,
unmute.
Jyoti, unmute yourself. Dr. Jyoti?
Yes.
Yeah. What is we used to use the digoxin in the heart failure previously. But what is your opinion? What is the status of the digoxin in the heart failure?
Yes, this is a very nice question. There is a proverb that's old is gold, but it may not be always true. So at the beginning, for the centuries, in the treatment of heart failure, digoxin played a very important role. Whether patient is in sinus rhythm or patient in atrial fibrillation, digoxin and diuretics are the standard modality of treatment. What we have seen during our student life internship. So gradually, with the evidence build up, and then it was shifted that digoxin in heart failure only applicable if the patient has atrial fibrillation. Again, the science has progressed. So many new avenues have come, and at present there is a one meta-analysis consisting of 37 trials. In this trial, it is seen the huge number of patients has been involved. So patient receive the digoxin, and you see there is a relative risk, increased relative risk of the all-cause mortality. So to some extent, the use of digoxin has reduced the morbidity in terms of hospitalization, but mortality is not reduced rather than increased. So with the hazard ratio of 1.17 and 95% CI, that means in current modalities of practice, digoxin is not advocated whether patient is in, particularly in sinus rhythm, also not in the actual fibrillation.
Thank you, Dojyoti.
Thank you.
So, after a discussion, I would like to ask the Dr. Mangesh. Dr. Mangesh is there?
Yeah, absolutely. I'm very much here, sir.
What is the role of the diuretics in the acute phase only?
Usually, yes. And as everybody has rightly pointed out, even Dr. Wonder has beautifully said that if there are 4 pillars of heart failure management, and where one is ARNI versus ACE inhibitors, second is beta blockers, third is SGLTs, and fourth are MRAs. So at the top, where there is a congestive phase of heart failure presentation, and this, especially I'm talking about heart failure with reduced ejection fraction. Well, that is the place where diuretics should come as a first choice of therapy. And of course, as far as SGLTs are concerned, apart from their benefits in the heart failure with reduced ejection fraction, as beautifully Dr. Wonder sir has also said, that the drugs which are not really been challenged, where the drugs which were now available for us to treat even heart failure with reserved ejection fraction, SGLTs probably will have a little edge over the rest of the therapies, along with diuretics, whenever you are trying to treat heart failure with the preserved ejection fraction or even a mid-range ejection fraction.
Thank you. You mean the decompensated patient, we have to give the diuretics?
Should be the first choice of the therapy.
After stabilizing the patient, we have to start as early as possible SGLT with the ARNI, so that we can reduce the hospital admissions.
Yes.
Dr. Wonder Singh. So after a discussion, so it is a very useful drug. It has changed the scenario of the heart failure management, I think. So now, I think no panelist, any panelist want to say something?
ठीक है, ARNI has come. Can you hear me?
Yeah.
ARNI has come, but I think if a patient, Dr. Wonder will agree with me, in our country still, heart failure, you need to treat them lifelong.
Yeah.
And cost and economics, they always remain a very important, criteria.
Absolutely.
As far as while, making a decision about putting a patient on a particular drug. And with all these 4 drugs there we are talking about, be it ARNI, be it dapagliflozin, be it MRA, I think the cost increases, substantially. So somewhere, I think, for example, if a patient is doing well on ACE inhibitors or ARBs and he's fine, though latest guidelines, they do recommend that you try to shift them. But I think, in every case, you have to individualize the treatment. So let us not make general statements. You have to individualize. There are several factors to be kept in mind. Then ARNIs, you must remember that they can be used only in class 2 or class 3, stage 2 or stage 3. But ACE inhibitors or ARBs, they can be used in, even class 4 also. That is another point that you must keep in mind. And it is not that they are absolutely safe. You have to keep, as Dr. Taneja was, trying to point out, as far as SGLT2 are, concerned, then non-ketotic euglycemic ketoacidosis. That is another thing that you have to be on the lookout. So, after balancing all the facts, then you, modulate treatment of the patient accordingly.
I think final word from the doctor.
One thing I want to ask one question.
I agree with Dr. Chawla.
I want to ask
on
one question to
both of them are extremely out of bounds for majority of the Indian population. See, unless there is significant change in the policy for the government to reduce their cost, both the drugs, ARNI as well as SGLT2 inhibitors, majority of the Indian patients are not able to afford, without a doubt that they are highly efficacious drugs. But we need to also take into account that these drugs need to be given almost lifelong. We'll need to be given to give these drugs to the patients for a long. And one of the most important factor for any patient is the compliance. One factor which can actually precipitate things is the compliance. And it is extremely difficult to expect our Indian patients to be compliant with these two drugs unless the drug is reimbursed or the affordability of the patient is beyond doubt. Otherwise, majority of the patients will go back to, and I agree with Dr. Chawla, ARBs and inhibitors are doing extremely good things. However, yes, there is an additional benefit of this drug in a particular set of individuals which scores over enalapril and ARBs. And similarly, SGLT2 inhibitors, there's no doubt about their efficacy, but the cost still is a major issue in most of them.
Yeah. Dr. Wonder, please.
I want to ask one question.
Yes, go ahead.
I want to ask
Go
one
ahead.
question. Many of my patients, which I put them on ARNI, they develop hypotension. Means their systolic blood pressure remains around between 90 and 100, and they feel very fatigued and weakness. And
Dr.
sometimes
Wonder
I have to stop that drug.
Dr. Wonder will.
Yeah, I think what Dr. Chawla point that he made is very, very important. That see, this is a lifelong treatment, and we have to use one of the three RAS blockers, whether you use ACE inhibitor or an angiotensin receptor. Just as he said very rightly that there are some beta blockers, only 3 beta blockers which can be used. Even for RAS blockers, only valsartan and losartan are the ones which have been used for heart failure.
Candesartan also.
So, telmisartan,
barely used, I think.
So telmisartan is a very good drug for hypertension, but telmisartan is not a drug to be used for heart failure. So we have to keep in mind that certain ARBs are to be used in heart failure. And it's the valsartan actually which has been most extensively evaluated. So if you, but between ACE inhibitor and valsartan, most guidelines say that prefer an ACE inhibitor. Intolerant patients, then you can shift to receptor blocker. Don't use receptor blocker as a first choice. And as Dr. Chawla was rightly saying, see, I see a lot of people being put on low dosages of ARNIs as compared to, whether you are using a beta blocker, whether you are using a RAS blocker, it is very important that you reach the guideline directed dosages. It is one thing to just start these drugs, but gradual escalation of the dosages to impart the maximum benefit, that is equally important. Just as enumerating in your mind that I have started all 4 drugs doesn't serve the purpose. Beta blockers have to be adequately used in its right dosages. Either of the 3 RAS blocker that you use. See, ARNIs are the most expensive drugs today. So SGLT2 inhibitor dapagliflozin is now off patent. We know dapagliflozin is very cost effectively now available in our country. The problem is with the ARNIs. ARNI has not gone off patent yet, and ARNI is still very expensive. So we have to, I have no hesitation in using an ACE inhibitor over an ARNI. But my issue is that all patients should be given a RAS blocker, a beta blocker, and a MRA along with an SGLT2 inhibitor today in heart failure. There is a lot of now discussion which is going on that whether we should even discuss ejection fraction or not, because the mid-range ejection fraction heart failure patients behave just as heart failure with reduced ejection fraction. So if you have ejection fractions up to 55 and your patients are presenting with breathlessness, they have raised BNP levels, almost the treatment is similar, but we very well know that the amount of benefit that RAS blocker, beta blockers impart as the ejection fraction goes up in this range, the amount of benefits are less as compared to heart failure with reduced ejection fraction. There's another last point I'll just make before. Very important thing is that once you give beta blockers to your patients, they improve the ejection fractions to the maximum extent. And a lot of your patients will ultimately, who are heart failure reduced ejection fraction, you will see them coming with ejection fractions of say 50%. Now, if you stop these agents, they will come back to you with heart failure, their ejection fractions will go down. So patients have to be convinced that even if your ejection fractions have come back to normal it is courtesy these drugs, and you will have to continue these agents. To answer Dr. Taneja's point in very short, in one word, well, it's the organ perfusion. If your patient is tolerating a blood pressure of 90 to 100 and has no hypotensive symptoms, one should not withdraw these agents, and one should, because these are mortality reducing agents. In fact, what you should reduce is a diuretic. A lot of my patients today of heart failure are not on any loop diuretic, but they are just on these 4 agents. Once you make them euvolemic, they start tolerating RAS blockers. So if you have to withdraw the loop diuretic once you are sure that your patient has been made euvolemic.
One absolute indication for ARBs, would be angioedema. In that case, you can't use ACE inhibitors, you can't use ARNIs. I think Dr. Munjal has joined us. I would like to welcome him and say a few words. Dr.
Dr. Chawla, ARNI, there is no problem in angioedema because ARNI doesn't contain an ACE inhibitor.
Yeah, it is more with ACE inhibitor.
Sir, I would like to add, ARNI has got neprilysin inhibitor. Yeah. And that also breaks down bradykinin.
No, I'm sure the angioedema
it does cause angioedema.
Please let me complete. Angioedema with ACE inhibitor is a drug reaction.
Bradykinin.
Yeah. Bradykinin. Same thing is with neprilysin inhibitors also. They also interfere metabolism of bradykinin, and that is how they cause angioedema. I'm sure about it.
Dr. Wander, if a patient is on the ARV, then if you start the ARNI, then how much time you require to start the ARNI?
See, if your patient is on ARNI, then you can straight away switch to from an ARB to an ARNI. If your patient is on an ACE inhibitor, then you have to give a 36-hour interval before you put these patients on ARNI. Okay. But from a valsartan shifting to an ARNI, there is no need to give a pause.
Okay.
I think we need to welcome Professor Munjal, who has joined us, and we can seek his blessings, please.
Dr. Munjal, please. Dr. Munjal, please.
Can you see him?
We can see him, sir. Unmute karna, sir.
Sir, Dr. Munjal, sir, please unmute yourself, sir.
Sir, unmute कर लो, sir.
हुआ नहीं सर, अभी अनम्यूट नहीं हुआ सर.
अनम्यूट नहीं हुआ. अतुल फोन करके बोलो बेटा. अतुल फोन कर.
मैं कर रहा हूँ.
डॉक्टर वो है.
राहुल उनका अनम्यूट करो सर को. मिस्टर राहुल.
यस सर, यस सर.
डॉक्टर वाईपी मुंजाल को अनम्यूट करो. लास्ट में डॉक्टर वाईपी मुंजाल, यशपाल मुंजाल.
डॉक्टर
यशपाल मुंजाल.
यशपाल, अच्छा लास्ट में है. या सर मैंने किया उनको.
अनम्यूट करने
योरसेल्फ.
हाँ ये
हो गया सर, हो गया सर.
नहीं अभी नहीं हुआ, वापस चला गया. हो गया
नहीं आ गया.
Okay.
Yes sir.
Good evening everyone. It is a pleasure that such an important topic is being discussed. I just have to say 2 words, that congestive heart failure a few years ago was equivalent to malignancy in the morbidity and mortality. All the agents used at that time were predominantly to reduce the symptoms. But today, as we have just heard Dr. Wander, that the agents which are now available, they prolong the life and also reduce the symptoms. We should continue to use them. And with this, I welcome Dr. Thakur Dr. Alka Deshpande, the Secretary of API, and our dear Chairman, Dr. Chawla, and Dr. Atul Bhasin for arranging such a beautiful program with the help of Dr. Chhabra. Thank you very much.
Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.
So, thank you very much, sir. So now,
Thank you.
if there is no question, then I will hand over to the mic to the Dr. Agamora. Dr.
Thank you
Agam,
very much. It was fantastic program, and success of any program is in its moderation. Dr. Chhabra, you moderated it so well. You could get the best out of the faculty, and I must compliment Chawla sir, Ponder sir, Mangesh, and Singh sir for giving their fantastic inputs. Dr. Taneja also gave a very nice case scenarios and the practical tips, which would, I'm sure, help all delegates manage their heart failure cases better. And icing on cake was Dr. B.B. Thakur and Dr. Munjal sir's presence and the blessings. I would now invite Dr. K.K. Parikh sir to give the final concluding remarks. Dr. Parikh sir is the director of Parikh Hospital and Research Center at Kota. He was the past president of Indian Medical Association, past president of API, past dean of Indian College of Physicians. With those words, I present Dr. Parikh to you.
Thank you, Dr. Agam. Am I audible?
yeah.
Good evening, friends. It has been a fantastic, excellent discussion on a very important topic of heart failure and use of ARNI and SGLT2 inhibitors. These two molecules in last 1 decade has revolutionized the treatment of heart failure. As told by Dr. Wander, that the 4 pillars for heart failure, the 2 problems which I see practically, that the hypotension and the cost of ARNI, which are very, ARNI is quite high, and it is very difficult to continue for almost a middle class person. The most common thing is that there is always, because in heart failure, there is a reduction BP, and with the start of ARNI and SGLT2 inhibitors and MRI, so there is a definitely fall of blood pressure. But even if you start sequentially with lower doses, even then we have to be very particular about blood pressure fall, because that can really create a problem for a heart failure patient. The very nice replied by Dr. Wander, but still, when blood pressure goes below 80, I think we should be very cautious to use these molecules together. We can start and we can reduce the dose of diuretic and then reduce the doses of ARNI, or even for ARNI, we have to build up the doses, even as like beta blocker, we have to build up the doses, start with the lower doses. So it was really a pleasure for all of us for listening every stalwart of medical fraternity, moderators, all moderators, Dr. Wander, Dr. Singh, Dr. Mangesh, Dr. Ashok Taneja, Dr. Chhabra, and everybody. So it was really, and I would like to compliment and congratulate the Delhi chapter of API for organizing such a webinar on such an important topic, and nicely moderating so that every part of this topic has been discussed so nicely that things are very, very clear. How to start, how to go, how to build up the doses, what to start and what not to start. So thank you very much for giving me this opportunity to conclude this very important webinar. Thank you very much,
sir. You've narrated the entire 1-hour discussion that we had, and your message is really going to be useful. I'm sure those, as I can see on my screen, some 780 or 800 odd doctors do not also want to leave this platform. Who would want to miss this opportunity of being with Munjal sir, Thakur sir, and Dr. Chhabra sir's conducted such nice program, but things have to end. And I would now invite, for the vote of thanks, my close friend, Dr. Atul Bhasin. Dr. Atul Basin is your General Secretary of API Delhi State Chapter and my close friend and my governing body member of my Association of Physicians of India, Director and Senior Consultant Internal Medicine working at BLK Super Specialty Hospital. With those words, over to you, Atul Bhai.
Thank you, Dr. Agam. Thank you for such nice words. Now comes my pleasant duty to thank each and every member who was present here today. But before we close session, I would like to put in a few words here about the drugs which we have. As we have seen, there are many adverse effects of many drugs which we generally use. So on 15th of March, the FDA has given a warning or a recommendation that patients who are undergoing surgery because of dehydration, there is a chance of precipitation of ketoacidosis in patients who are being treated with SGLT. So they should be ideally stopped on this medication for 3 to 5 days before prior to surgery. And they have also found that there is an increased incidence of pyelonephritis. So I think these two things which are new to us, we need to be very, very careful when we are using these drugs for these patients. With these words, I would like to thank each and every member today and all the delegates who are attending this meeting today, which was conducted by API in association with API Delhi State Chapter. I would like to thank Dr. Alka Deshpande, who is the Dean of Indian College of Physicians, and Dr. Shyam Sundar, the President of Association of Physicians of India, who helped us in conducting this CME program today. The ever guidance of Dr. Y.P. Munjal and Dr. B.B. Thakur, who have been the guiding force behind all the academic feast throughout the last few decades for API. I think we need to thank them especially, and Dr. Y.P. Munjal also, who joined late, but we thank you, sir. You have joined us. I would like to thank our new secretary, Dr. Agam Vora, for introducing each and every member in such a manner that as if, we have been a part of his life throughout. So I would like to thank Dr. Agam Vora. I would like to thank Dr. R.N. Chabra, who has been a force behind API Delhi State Chapter in conducting CMEs over past 1.5 to 2 years, and having such a beautiful panel discussion with chairpersons like Dr. Girish, Dr. Jyotirmay Paul, and Dr. M.P.S. Chawla, who is our chairman today. I would like to thank Dr. Shashank, Dr. Wander, Dr. N.P. Singh, and Dr. Ashok Taneja, who are the doyens in their specialty, for guiding us and telling us the basics of what and how to use these drugs. I think that has been a great advice. My special thanks goes to the advisors and conveners of today's meeting, Dr. K.K. Tiwari, Dr. Preetam Gupta, and Dr. Rajesh Upadhyay. And my special thanks also goes to Dr. K.K. Parekh for giving us the conclusion remarks. With this, I would like to close the session. But before I close this session, I would like to thank Lupin, who have given us this platform to conduct today's CME. With this, I will close the session too. Thank you, everyone.
Thank you very much
for joining us
Thank
today.
you, everybody, for your time, your presence, and all delegates. It's only because of you we are able to do such programs. Thank you.
Yeah.
Thank you.
Thank you.